Hello, I am Debbie Rodger, the HIV Strategy Nurse Consultant with the Ministry of Health of Saskatchewan. The following webinar was prepared by myself and Roxanne LaForge, who is the Perinatal Education Program Director at the Continuing Medical Education College of Medicine, University of Saskatchewan. Roxanne does not have any disclosures. I do have a disclosure. I did receive an honorarium from Merck for an advisory board in September of 2015. The objectives of the following webinar will be to describe the incidence and impact of HIV in pregnancy and prevention initiatives to reduce maternal-infant transmission of HIV. Secondly, we will describe the standards of care for women living with HIV during labor, birth, and immediate postpartum period, and appropriate care for the newborn. And third, we will discuss the implications for the implementation of these standards at the local and regional level. These guidelines were developed over the last couple of years and were released in December of 2015. And this webinar is part of a series of presentations we will provide to sort of disseminate these guidelines across the province. Our goal, zero mother-to-child transmission of HIV. The basics of HIV and pregnancy will be discussed, an overview of the epidemiology of HIV in Saskatchewan, Saskatchewan's HIV strategy from 2010 until 2014, development of perinatal HIV prevention protocols. We will then look at the overview of the prevention protocols and their resources, and review recommendations for best practice in caring for women in labor and care of the newborn. Considerations in implementing these protocols in healthcare facilities and capacity with obstetrical services and without obstetrical services. So let's get on. What is HIV? Often clients will talk to you about the fact that they may have AIDS or may refer to themselves as a person that is AIDS, where really we're talking about HIV. They have acquired the virus. AIDS is a term. It is not interchangeable with the acronym HIV. HIV meaning human immunodeficiency virus. AIDS meaning acquired immunodeficiency virus. How do we transmit HIV in Saskatchewan? How is HIV spread? In Saskatchewan, the most common way of transmission is through injection drug use. Across Canada, that is not so. Most commonly, it is spread through heterosexually, but in Saskatchewan is the injection drug use, which can lead to chaos in many persons living with HIV. Who should be tested? The province also has routine testing guidelines, which we will talk about, where you can find those at the end of the presentation. And these routine guidelines talk about who should be tested, how frequently they should be tested, and how to do pre- and post-test counseling. What are the current trends in treatment for HIV? We like to see all of our clients on medication. It is available across the province in consultation with infectious diseases specialists. Our current thoughts that everyone should be offered treatment. Some of the treatments can be as simple as one pill once a day. Clients may ask you, what is their life expectancy? With proper treatment, engagement, and linkage to care on medication and having a non-detectable viral load, we would like to think folks have a normal lifespan. We know that stigma and discrimination still exist, in part probably due to lack of education. And we also want to ensure that our clients have cultural safety. And most importantly, which is documented several times during the protocols, confidentiality. If we don't have confidentiality, we won't be able to help our clients become linked and engaged to care. We know now that with diagnosis and early diagnosis and clients being on medication, pregnancy is a reality. Many of our clients do get pregnant, often in consultation with their infectious diseases specialist as a planned pregnancy, but not always. Sometimes they come and come to us unexpectedly for our care. There are definite options for conception that are available, and we like to think that our clients get on medication as early as possible in their pregnancy, or continue their medication if they were already on. They should stay in continued contact with their HIV specialist and do frequent, if not monthly, blood work. And these will all help in the prevention of perinatal transmission. This slide shows us the epidemiology of HIV in Saskatchewan. So we can see that we are twice the national rate back in 2007 to 2013. And in 2014, we're 1.5 or 1.5 times the national rate. New cases of HIV began to spike in the 2008-2009, but since they have begun to slowly decline. Saskatchewan is unique from the rest of Canada. Injection drug use is the highest self-reported risk factor in acquiring HIV infection. And we note also that women of childbearing years, so those will be considered women ages 15 to 45, are disproportionately affected. Approximately 25% of all new cases in 2013 and 2014 are women in this childbearing age. Due to the rising numbers of HIV that were noted in 2008-2009, Saskatchewan developed an HIV strategy that lasted from 2010 to 2014. Approximately $4 million per year were invested since that 2010-2011 year, with some of the key outcomes: decreased perinatal transmission of HIV. From 2003 to 2010, there were 9 perinatal cases of HIV transmission reported across the province. Between 2006 and 2011, there were 6 cases of perinatal transmission. That report represented about 21% of Canada's total HIV perinatal transmission. Improvements in HIV testing, treatment, and support have led to no further transmissions up until the end of 2014. We also developed an infant formula program, and it has been integral in preventing transmission of HIV through breastfeeding. This formula program, which will be discussed later, provides free formula for moms living with HIV for their newborns. The Society of Gynecology and Obstetrics Clinical Practice Guidelines in 2006 had minimal direction around women living with HIV who wanted to become and how to maintain their pregnancy. It offered testing to women with no prenatal care and unknown HIV status on admission to the labor room. It discussed women at high risk and unknown status to offer HIV prophylaxis in labor. When they redid these guidelines in 2014, they published 24 recommendations for antenatal and interpartum care. So there was a great increase in the amount of information and direction and guidance they provided. They talked about IV zidovudine, or AZT, being initiated as soon as onset of labor until delivery, in combination with the client's oral combination that they probably were already on before they came into labor, regardless of the mode of delivery, current antiretroviral regimen, or viral load. HIV-exposed newborns should also receive antiretroviral therapy for 6 weeks to prevent the risk of vertical transmission of HIV. The Canadian Pediatric Society Clinical Practice Guidelines also talked about HIV testing being offered routinely to all women as early as possible during pregnancy, and repeating later in pregnancy if there's ongoing exposure suspected. So this will be ongoing risk. HIV status of pregnant women must be available and communicated to teams caring for her at the moment of delivery. It talks about failure to ensure availability of this information may dramatically increase the risk of neonatal HIV acquisition. It also can result in unnecessary exposure of the newborn to antiretrovirals. Empirically, infant therapy is sometimes started in very high-risk situations pending results. So meaning that if we do not know the status of the mom when she presents in labor and birth, and we know she's at high risk, we may empirically start that AZT until we do know the results of her HIV serology. It also addresses the need for comprehensive, accessible programs for HIV testing in pregnancy that result in informed testing of women and provide appropriate follow-up and care for HIV-infected women and their children. These programs must be evaluated for their effectiveness, and this information was reaffirmed in February of 2013. The Saskatchewan Prevention Institute, and you can see some of their posters, which are available on their website and are great additions to waiting rooms. They have a multifaceted approach to perinatal HIV. The HIV Pregnancy Advisory Committee, which is supported by the Saskatchewan Prevention Institute, is interprofessional, multi-sectoral advisory committee. It does environmental scans and literature reviews, does e-learning events, provides hope for the future, having a healthy pregnancy living with HIV DVD, which can be also found and accessed through their website. Provides grand rounds, and as you can see there, the posters, brochures, and information available for women and for professionals. What do you think about a Saskatchewan scenario? What might we meet when we're talking about a Saskatchewan scenario, and what might it look? A woman presenting to a hospital and verbally indicates that she's HIV positive. Well, there's no documentation, no HIV status, when was she tested, what's her viral load. The healthcare team did not have access to HIV testing at this local facility. No point-of-care testing was available, no medication, no familiarity with the protocols to initiate HIV treatment. They do very few deliveries potentially at this small rural facility. The woman was referred to a larger center and then transported by ambulance. Still no record of her HIV positive test was available. The physician ordered a stat test. The fetal heart rate was low. A scalp electrode was attached to monitor the baby's heart rate. The mother progressed very quickly, and due to profound fetal bradycardia while pushing, forceps were used to expedite vaginal delivery. The mother delivered the baby before the HIV test results were available. She was positive. Antiretroviral therapy was administered to baby 2 hours after birth. What do you think? What was the outcome for the baby? Was the baby positive? Was the baby negative? Keep this scenario in mind as we further our webinar. We know that an HIV infected woman may present to any hospital emergency department or labor suite in the province. HIV status may or may not be immediately available to the physician or other healthcare providers attending the birth. For a variety of reasons, women may or may not be forthcoming in divulging their HIV status or risk factors to the obstetrical centers, and increasing difficulty in decision-making may occur. We know that women who feel in a threatening situation, if they feel if there's stigma or discrimination, they haven't had time to develop a trusting relationship with a healthcare provider, they may potentially not divulge their HIV status. The perinatal transmission risk of HIV without any preventative measures is between 20 and 35%, and this is as per the U.S. Centers for Disease Control and Prevention. In Saskatchewan, there is approximately 15,000 births in Saskatchewan hospitals annually. We know that women whose HIV status is unknown includes about 2 to 5% of pregnant women who opt out of testing during prenatal care, women who may receive an anonymous HIV test, women who have no or limited prenatal care and thus may not have had a recent HIV test, and women who have ongoing risks for acquiring HIV during the pregnancy, even if they had an early pregnancy HIV negative test result. So after talking about all those risks, we wanted to develop some guidelines, some help for those across the province for any type of client that they might meet that has risks, that may or may not have an HIV test. So the drafting process began. The HIV Prevention Leadership Team in the Ministry of Health developed an HIV and Pregnancy Advisory Committee, which was led by the Saskatchewan Prevention Institute and chaired by Dr. John Mark Fondo. The mandate to developing standardized practices, tools, resources for professionals and the public care and tools that can be used across the province when delivering babies to women living with HIV. Orders and existing resources were reviewed and modified. So there was orders that did exist in the larger tertiary centers in Saskatchewan and Regina. There was also some resources developed nationally in Northern Alberta. Haiti developed a great resource called the Maternity Kit, and British Columbia also had some great resources that were reviewed. Subcommittee began developing some drafts, and this includes Nicole Kimball, who is a nurse at the Positive Living Program in Saskatoon, Roxanne LaForge of the Perinatal Education Program, Ellen Couture, a pharmacist in Humboldt, Shannon Stone, who at the time was a pharmacist with the Positive Living Program, Mike Stuber, pharmacist with the HIV Prevention Leadership Team, and Jackie Eaton with the Saskatchewan Prevention Institute. The drafting process continued. Drafts of the Maternal, Labor and Delivery and Infant Orders were shared with HIV and Pregnancy Advisory Committee back in November of 2013, and some Further drafts were reviewed by Dr. Van Tan, who is a pediatric infectious diseases specialist with the Positive Living Program in Saskatoon, Stella Magnuson, nurse practitioner at Westside Clinic, Dr. Stephen Sanch, infectious diseases specialist at the Positive Living Program, Dr. Athena McConnell, who's also a pediatric infectious diseases specialist in the Saskatoon Health Region, and Dr. Apondo, the medical health officer and part of the HIV Prevention leadership team. Dr. Chan shared that final algorithm draft with neonatology, HIV obstetrical, and pediatric specialists from Saskatoon, Prince Albert, and also forwarded them to Dr. Skinner here in Regina. The drafting process continued then further with an external review, which was completed by Dr. Mona Lufti, who is an infectious diseases specialist, and Logan Kennedy, her specialized registered nurse, and they both practice in Toronto at the Maple Leaf Clinic. Further expert review was then carried out by Dr. Chan, Nicole Kimball, Mike Stuber, and Dr. Alexi Rabush, who's an obstetrician in Saskatoon. These provincial HIV perinatal protocols and resources include a lot of different documents, and these include guidelines for maternal newborn assessment and care, and these include care for the pregnant women living with HIV interpartum and postpartum, care of the infant, which includes feeding, a referral, and phone numbers. Several care pathways were developed to assist in clinical decision-making for women. These included 3 pathways. One talked about the woman who is known to be HIV positive. She comes, she admits, it indicates who she is HIV positive, and then we talk about whether or not she was taking her medication or not, so and what her current viral load is. Then the second pathway talks about where the HIV status is unknown. A woman may have been at risk, may not have had any prenatal testing at all done, and there is point-of-care testing or stat testing available at the facility that she has presented at. The third pathway talks about where the mom has been at risk or maybe never had an HIV test be done before, and no prenatal care, but she does appear to a facility that does not have the ability to provide a point-of-care test or stat testing. And some of those do exist across the province. Another resource is the physician pre-printed order templates, which address the clinical scenarios addressed above, including specific interventions for management in labor, management postpartum care, infant feeding, and discharge planning and referral. The perinatal HIV prevention protocols and resources also include specific documents related to the infant, physician pre-printed order template, that is infant HIV referral form, and discharge instructions. Staff review with the infant care provider, mom, or if someone else is caring for the child, information prior to discharge, and ensure the care provider knows how to correctly mix and store formula, as well as the drug, the AZT, and it talks about the infant formula program policies and procedures and how to access and maintain continued contact with the program. The infant care provider also, there's a sheet that talks about frequently asked questions about HIV, about pregnancy, about babies, and discharge instructions. This is the link, so you can find all of these protocols at this website. If you go to www.saskhiv.ca, you can see where the arrow is. It talks about the perinatal HIV prevention protocols, and that's where you would find all of the information that we've just discussed. If you see above, there is, if you're unsure about the testing protocol, how to pre- and post-test counseling, you can see above where it says Saskatchewan HIV testing policy. That will give you the latest testing policy. It is best to access these protocols when you need them from this site because there is ongoing updates. So if you will be getting the latest set of protocols if you go to this website and actually access these protocols at that tab there that is shown by the arrow. Further down, you can see some other interesting things. The infant formula program, there's a specific tab for that, and it discusses in great depth the infant formula program. Other contacts across the province, the HIV strategy coordinators. You can see some community-based organizations. If you feel any of your clients might need some assistance out in the community, those are great resources there. There's other learning opportunities that are based on HIV Grand Rounds, some other training and education Opportunities are on the other tab, and then there's annual reports for Saskatchewan can be found in the last tab. So it's a great all-around website. The key messages of the perinatal HIV protocol, prevention protocols are all about best practices, and we'll discuss a few of those. So risk assessment is critical for all women. We need to identify, is the woman at risk? Maybe she had a test early in her pregnancy. Does she need to be retested? So it guides the implementation of the HIV prevention protocols. The very first sheet does that risk assessment. It identifies the most important appropriate care pathway for the woman, including the pre-printed orders for mom and infant. Not tested for HIV in pregnancy, before pregnancy, during the pregnancy, at what time, at what point in time in the pregnancy was the HIV test done? Tested, but she doesn't know the results. Tested, but the results weren't available. HIV negative on a previous test, but still has ongoing risk factors. So it answers all of those types of questions that you might be thinking about. How do we ask them those difficult questions? If we're not really comfortable asking those questions, we need to think a little bit about approaching the mom with a caring and non-judgmental attitude. Your body language, your comfort with asking the difficult questions, ensuring that we have privacy and confidentiality as much as possible in your environment. Let the client know that the questions you're going to ask, you ask of everyone, regardless of their age, their gender, or their marital status. And ensure them that the information ensures the health team can make appropriate decisions to guide the best care for her and, most importantly, for her baby. Use gender-neutral language. So when applying these prevention protocols, we're assessing the risk factors. We're including their current medication use, so we need to look at their prevention tips and see how they've been doing with their medication. Have they been able to take it on a regular recurring basis? We want to look at the last blood work. What was their most recent HIV viral load? And questions that assist in the follow-up with the infectious diseases specialist. So when you're making that call to talk to the expert in Saskatchewan or Regina, you want to ask the mom those questions. You want to know her HIV status. When was she last tested? Has she been taking her medication? She says one thing, but perhaps her provincial profile is telling you that it doesn't look like she's picked it up for the last 3 months. So you need to have all these pieces of information before you make the call. The maternal pathways summarize approaches to maternal and newborn care. So they talk about the mom who's known to be HIV positive, the mom where you don't have that status of that HIV status available to you, the mom where you don't know what her status is and we don't have a test. Also may apply to women with an HIV negative status. So early in the pregnancy she was HIV negative, but she talks to you about some ongoing risks. Perhaps her husband is known to be HIV positive and they've had some unprotected sex. Maybe she has had some ongoing injection drug use or some ongoing addiction issues, so she maybe needs to be retested. Decisions also regarding the route of delivery, vaginal versus cesarean birth, and location is based on risk factors, viral load, and obstetrical indications. Women assessed at high risk. So these are women who self-identify as having been at high risk of HIV, a sex partner of a person who is known to be HIV positive, ongoing injection drug use, or sex with a person using injection drugs, diagnosis of a sexually transmitted infection during pregnancy. They're from a population with a high prevalence of HIV. So that means, were they recently incarcerated? Were they a recent immigrant to Canada or a refugee from an endemic country? At the bottom is a resource. It's a great resource that will take you to a site that BC has that will identify whether an immigrant has come from an endemic country, a country where there is a high rate of HIV. We always want to ensure during this whole process that we are providing confidentiality and privacy of information. This is critical. You will not get a trusting relationship with your clients if you do not assure them and make them feel comfortable that their personal health information is being kept confidential and private. To ensure that confidentiality of that maternal HIV status, obtain and document verbal consent. It needs to be verbal. It does not need to be written consent from the mother to share information about delivery, viral load, and HIV medications with the pediatric HIV specialist for the follow-up baby care. The mother should be informed that disclosure of HIV status to public health is required for follow-up and to facilitate postpartum care. And this is a piece that will happen afterwards. If mom has been identified as being HIV positive during this laboring process, after she has begun her recovery postpartum, there will be some contact between herself and public health to identify partners or partner trace the processes that public health needs to take as partner tracing. Best practices, labor and birth. Continue current antenatal HIV antiretroviral regimens throughout the labor and beyond. So if mom comes in and she's on antiretroviral medication already, she should continue it through the laboring process. It discusses initiation of the IV zidovudine with rupture of membrane at onset of labor, spontaneous, induced, or preterm, at least 3 hours prior to a planned cesarean section, any situation where delivery is anticipated, during labor and delivery to the mother as per the algorithm. It indicates the loading dose and continuous infusion dose per kilogram as per the pre-printed orders. It also talks about if her labor stops. If the labor stops and the infusion is discontinued for greater than 6 hours, you need to re-administer that loading dose and resume infusion when the labor does resume. Best practices also talk about avoiding invasive monitoring during labor and delivery unless absolutely necessary. So as we talked about in that little scenario we were talking about, some things that happened in that situation, we do want to avoid internal fetal scalp electrodes. We do want to avoid intrauterine pressure catheters and fetal scalp sampling. Also avoid, if possible, unless obstetrical benefits exceed risk, artificial rupture of membrane, forceps, vacuum extractor, and episiotomy. Standard GBS prophylaxis applies as indicated, so that is group B strep. Use standard universal precautions using gowns, gloves, masks, and eye protection at delivery. And that should be done with every client. That is nothing special, it's just a reminder. Best practices postpartum and newborn. Bathe the infant as soon as possible once stable and prior to IM injections, and it discusses it in a complete form on the orders. Limit blood sampling unless required for urgent medical reasons. Isolation of the mother and baby is not required for infection control. Initiate antiretroviral medications to the baby. Support the mother and the care provider in independent administration of medication to the infant for accurate technique. And we want to ensure that mom or the care provider are totally comfortable before we discharge baby to their care. Discharge instructions should be discussed with the mother and care provider, and this would include such things as follow-up appointments, what to do if you run out of the AZT medication, lots of reminders for mom, and most importantly, contact information if she runs into a problem or has a question that she feels uncomfortable with. Infant feeding needs to be discussed. Breastfeeding is contraindicated for women with confirmed HIV or until unknown status is confirmed. So we need to do complete patient teaching reformula feeding. We need to consider the pharmacological, non-pharmacological options for lactation suppression and comfort. We need to initiate referral to the Saskatchewan Infant Formula Program and ensure access to adequate amount of formula prior to discharge. So what that line means is we need to make sure that when we're letting mom go from the hospital, that we're not sending her home with just one can of formula. We may be sending mom to somewhere in a remote area. In Saskatchewan, we need to make sure she has adequate formula until she can get a complete month's supply. The next slide talks about the infant formula program. So who's eligible for that program? Infants born to women who are HIV positive from birth to 1 year of age, unless the child is in the care of Child and Family Services. Infants who transition from Child and Family Services back to their mother caregiver up until the 1 year of age will become eligible. So it can be, mom needs to know about this program, and once baby comes back to her care, she then can access. But while child is in the care of Child and Family Services, formula is provided in a different manner. All children are able to benefit from it regardless of provincial or federal benefits that the mom or the child may be eligible for, and it is up to 4 cases of formula per month. The referral can be made by healthcare professionals, by nurses, by physicians, or by the individual themselves as a self-referral. And so this might be for someone who is a mom moving to Saskatchewan with an infant, late in her pregnancy, maybe hasn't been identified to anyone, hasn't linked to any particular program. She can link herself, or if she happens to move here when she has an infant that's 2 or 3 months old. And you can also find more information on the website about the eligibility, referral mechanism, patient education, billing and accountability at that www.skhiv.ca website. Healthcare providers play an important role in helping women and families understand the importance of safe infant nutrition. We want to do the best for their child. They may be scrutinized by others for non-breastfeeding. So these are things that we need to counsel our moms about. And there's some great resources around talking to mom about how to answer those difficult questions that may be asked in the postpartum period about why she's not breastfeeding. This is the first of the pathways, and we don't have all of the pathways here, but this is just used as an example. So you can see that this one is where the status is unknown or at risk, and there is no point-of-care testing available. You can see where it talks about assessing the risk, and it identifies does the mom self-identify for being at risk? Have you had to ask the questions to help identify those risks? Is the sex partner of a person who is known to be HIV positive? Do they have some ongoing injection drug use or sex with a person who uses injection drugs? Diagnosis of a sexually transmitted infection during pregnancy from a population with a high prevalence of HIV, as we discussed earlier. Confirm the history of HIV testing in pregnancy when assessing risk, and this can all be done through the eHealth viewer. So if you do not have availability and you would be a person needing to access this information, please go to eHealth and talk to them about getting access to the eHealth viewer, where you can find an HIV result no matter where it may have been performed across Saskatchewan. So you identify the women, and then you would go down one of the paths, either high risk or low risk. So if it's high risk and we're able to transport, you're going to want to transport that mom to a site where the drugs AZT and more specialized obstetrical care may be available. If she's low risk, you then may proceed with the vaginal delivery. There is no need for any medication for baby in the newborn period. It prompts you to call for advice. If you're feeling that you are not unsure of anything that appears on this pathway, by all means pick up the phone and talk to the on-call infectious diseases specialist, either in Saskatoon or Regina. If unable to reach one of them, there certainly will be somebody on call in Prince Albert, Saskatoon, or Regina for obstetrics, and they will help take you through these pathways. Where are babies born in Saskatchewan? You can see the facilities below with obstetrical services, and these facilities are all armed with the ability to provide STAT or point-of-care testing. And at this point, I'll just clarify, point-of-care testing is a test that is done at the bedside with the mom. It takes about 60 seconds to get a result, either a negative or a positive/indeterminate test. If it is an indeterminate or a positive test, blood will be drawn and sent off to the provincial lab for the confirmatory Western blot. It is 99.6% efficacy, so if it is a negative test, the mom is considered to be negative at that point. So a STAT test, though, is provided most commonly in places like Regina or Saskatoon, where the blood is drawn and taken down to the lab. The lab performs the test and gets the result back up to the labor and birth unit within 1 to 2 hours of having the blood drawn. And you will see that these tests are available in Sun Country at St. Joseph's in Estevan, in the Cypress Health region in Swift Current, in Regina Capel Health region in Regina, and at All Nations Healing Hospital in Fort Capel, in Sunrise at Yorkton facility, in Five House in Moose Jaw Union Hospital, in Saskatoon at the Royal University Hospital, in Prince Albert at Victoria Hospital, and in Prairies North at both Battleford's Union and the Northwest Health Facility in Meadow Lake. But what about babies who are born in Saskatchewan, where they can be born sort of everywhere, where there is obstetrical services but lack of capacity at present? Facilities providing obstetrical services on just an urgent or emergent basis. So this is a small little hospital where a mom is on her way potentially to a larger facility, but baby isn't going to wait and may end up on their doorstep in a much smaller facility. The capacity being the ability to do stat or point-of-care testing may or may not be available there, and their ability to administer required medications on site in a timely manner may not be there as well. Our goal, remember, is that zero mother-to-child transmission of HIV. So it's just food for thought. How are you going to use these previous resources in your workplace? Each health region needs to approve and adopt these protocols. And there has been discussions at a much higher level about dissemination of these protocols. You need to have a look at them. You need to form a committee within your health region. You need to talk about making them into pre-printed orders. That you then have the ability to put your own health region logo on them and adopt them as your own. You need to watch for these resources coming to a healthcare facility near you. And so it's really a good idea to go to the website, to review these resources, and make sure you're using that website. As I mentioned earlier, these will be the most updated and most accurate of these protocols available if you download them when you need them from that website, rather than storing a printed copy somewhere. So some of the discussion points that you need to take forward is to encourage testing. All moms need to be tested at least once during their pregnancy if there's an identified risk, more frequently during their pregnancy. We can't forget about mom and baby. They need support during the prenatal period. They need interpartum support, but they also need postpartum support. So please remember to support your moms. There's lots of things that they need to do, making sure their baby gets their AZT, accessing the formula program, lots of things in that postpartum period. And remember all the questions that they'll be asked about why aren't you breastfeeding. So they will need support and ongoing support. We need to make sure that that program is accessed by every baby born to an HIV-positive mom that's eligible in Saskatchewan. And we need to make sure that there's ongoing linkage in care. Baby needs to be followed up for lab testing ongoing for the first few weeks of its life. So it needs to be linked to either a pediatrician or to the pediatric infectious diseases specialist. Mom needs to continue with ongoing care and needs to have access to antiretroviral therapy as necessary. So we want to make sure that mom and baby remain linked to care in that immediate postpartum period. So if you have any questions, we will look at the next step. So one comment that we liked is the right care provided by the right provider to the right patient in the right place at the right time, resulting in optimal quality care. And we know that each person, each mom living with HIV is her own person. She comes from her own place, she has her own history, and her diagnosis and her HIV is all her own. So we need to provide her very individualized and specialized care. Here are some of the resources that we utilize and some of the resources that will be available to you. So as we talked about earlier, that Provincial HIV website, the Saskatchewan Prevention Institute has some great resources, so it's a great website to go to as well. And of course, CAIDI, the Canadian AIDS Treatment Information Exchange, has great information about moms and babies during that pregnancy period, but also lots of great information about HIV and hepatitis C. And you can also go to the Society of Obstetricians and Gynecologists, their guidelines of care for pregnant women living with HIV and interventions to reduce perinatal transmission. You can see that website below as well. So if this webinar raised any questions to you, or you have any ongoing questions when you access the resources, please feel free to contact us at contact@hivplt.ca, and we will direct the question to the most appropriate person to provide you with ongoing and up-to-date information. So I thank you for participating with us today and hope this was informative for you.